It's my pleasure to discuss some of the presentations at the EHA and ASCO. One of the abstract or posters we presented is the outcomes of KTX19 in patients with a relapsed refractory mantle cell lymphoma in ZUMA-2 who had progression of disease within 24 months of diagnosis. So everybody knows the first report for ZUMA-2 was at ASH 2019. At that time, the follow-up time was 15 months. Later on, the manuscript was published in the New England Journal of Medicine on April 1st of 2020. The follow-up time was 15 months. So later on, we presented in ASH 2020, we presented the longer follow-up data on the same trial in ZUMA-2. The follow-up time was 17.5 months. Meeting follow-up. So at ASCO and EHA, we presented the same data at a follow-up of meeting 17.5 months. However, in these two posters, in these two great meetings, we divided that according to a disease category called the progression of disease within 24 months, so POD 24. Why we select this? Because mantle cell lymphoma after initial therapy, if the patient relapses within 24 months, that's a bad prognosis. We want to see whether this also applies to our CAR T-cell therapy. So we presented several figures and tables, and the conclusion is that after a median follow-up of 17 months, in the KTX19 provided a high rate of CR in patients without POD 24, with the median duration of overall survival not reached in either group. So to be more exact, without the POD 24, which means without mantle cell lymphoma relapse within 24 months, the overall response rate is 91%. The CR rate is 72%. On the other hand, if the patient relapses within 24 months, the OR rate was 93%. However, the CR rate is dramatically much lower, 61%. So without progression, 72%, with progression, 61%. In this clinical trial, we also found that at the baseline, patient with progressed within 24 months likely have high-risk disease with high tumor burden, high ADH, and a high percentage of blastoid variant in that disease category. However, the safety profiles are similar among the two groups. And also patient with a progression of within 24 months to appear to have lower CAR T-cell expansion peak compared with this without relapse. And we think this data suggests that earlier intervention with a CD19 CAR T-cell therapy would benefit the patient with high-risk factors. Earlier intervention means we intervene at a low tumor burden rather than high tumor burden, and also intervene before the LDH become too high. So that's my comment on this presentation.